The topic of today will be about paraneumonic effusion and empyema. First of all, we will talk about the pleural space. The pleural space is a space between the parietal pleura, which is covers the chest wall, and the visceral pleura, covering the lung. Normally, in a healthy person, the pleural space would contain a few millimeters of fluid that act as a lubricant between the two surfaces. If pathological accumulation of fluid appears, so we call that pleural effusion. Pleural fluid normally originate in the pleural capillaries, lymphatics, and the intrathoracic blood vessels, interstitial pulmonary space, and peritoneal cavity. It is reabsorbed through the lymphatics of the parietal pleura. The mechanism that cause pleural effusion, normally, it all results from an increase for production or decrease in the removal of pleural fluid and may be related to changes in hydrostatic capillary, intravascular or extravascular colloid, osmotic and negative intrathoracic pressures. This is the mechanism of production of pleural effusion normally. Pleural effusion may accumulate due to changes in pressure, whether increase in the hydrostatic one, decrease in the colloid pressure, decrease in the removal of the fluid, increase in pulmonary interstitial fluid, or impaired the lymphatic drainage from the parietal pleura, or maybe movement of fluid from other cavities, such as the hepatic hydrothorax patients, where the fluid move from the abdomen through the pores of the diaphragm to the pleural space. Maybe also with decrease in the negative pressure within the pleural space, the fluid may migrate. Maybe vascular ruptures in the chest, like the trauma and the hemothorax. Maybe ruptures of the thoracic duct, as it's happened in chylothorax. Method used to investigate pleural disease, normally medical history, patient exposure, maybe if we are thinking of something like malignant or benign mesothelioma, current and recent medications. There are a lot of medications that can lead to that. Maybe some systemic disease like heart disease, liver disease, some neoplastic disease, some connective tissue disease, and some areas where TB is present. Physical examinations for the patient, complete physical examination should be performed. The overall picture provided the clinical variables, the medical history, the physical examination, the results of the tests. All of this may give a general idea of the presence of pleural effusion. Radiographic technique, any effusion more than 75 millimeters is visible on chest radiograph. Pleural effusion, maybe it's normal, you can say it's free flowing, like that which is present with transited pleural effusions, or loculated. We will talk about that in details as going through. And either typically or atypically cited. Typically, it's present normally, obliterating the angle, but some atypical site, like subpulmonic fissures with the fissures of the lung, or mediastinal sited. The amount of fluid varies when there is a doubt in case of small effusion. So we could confirm the presence of the effusion or not and its location by using the chest ultrasonography in a lateral decubitus position for the patients. Anomalies in the lung parenchyma can help to confirm the suscepted diagnosis. So if we are doing a CT, maybe we can think if there is a mass or if there is other pathology that may give us an idea about the suspected diagnosis with the underlying effusion. Thoracocentesis, pleural fluid should always be investigated, taking a sample, doing the thoracocentesis, except the only contraindication for doing it if it's clearly secondary to something like heart failure, like something like hepatic hydrothorax. We are not going into doing a lot of investigation because of risk of infection with treating of the underlying condition. The morbidity associated with thoracocentesis is very low. So it's approach to doing it for every patient for the first time, especially even the transited one. So it's not have a lot of morbidity or complications normally. In case of small effusion, thoracocentesis should be undertaken if the distance between the horizontal line of the pleural effusion and the chest wall more than 1 centimeter. It's confirmed by using the ultrasound machine to say it's safe to go with a needle. Thoracocentesis in very minority of patients can cause bleeding in patients where platelet count is less than 50. This patient must receive prior coagulation therapy. The most common complications are vagal reaction and pneumothorax. If piercing the lung, it can result in some air leak into the pleural space. A chest radiograph is not essential after doing thoracocentesis, except when complications. Maybe if the procedure is not straightforward, we can think of doing a chest radiography if we are trying to exclude something like bleeding or pneumothorax. The following properties of fluid samples are analyzed: the color and appearance. For sure, if it's pus, you are thinking of empyema. If it's milky, we can think of chylothorax. If blood, we can think of hemothorax. And also the smell. If the smell is putrid, we can think of infections, most probably likely due to anaerobic infections. And in case of urinothorax, which is a complication which is very rare, mostly is heterogenic, we can smell the ammoniac odor. In every patient, we have to think of doing the analysis. Normal analysis for pleural fluid, we are sending one for the biochemical analysis, for the biochemistry, looking for the glucose, protein, LDH most importantly. And the other thing, we are doing it when suspicious of other underlying condition. Triglyceride, maybe we are thinking of chylothorax, amyloid. If you are thinking of pancreatic cause of this effusion, it happens with pancreatitis, but it's very rare. Cholesterol also, if you are thinking of chylothorax or pseudocylothorax, ADA with TB, something. We can think also doing a microbiology when suspicious for gram stain, culture for aerobic and anaerobic infection, and the cytological analysis, especially if in suspicious malignant effusion. It's a summary for what we have said. Overall, the pleural effusion went into two things, like we can say transudate and exudate. Transudate is related to a systemic disease. Exudate, there is a problem in the pleura for sure, and that's why, as a result of inflammation in the pleura, it results in an exudate effusion. As a result of inflammation, injury, or malignancy, which can involve the pleural surfaces. So we are expecting that the pleura is not normal in exudate effusion, but in transudate effusion, there is no problem in the pleura, no problem in the lung. It's a problem present in a systemic disease. A lot of causes can lead to exudate effusion. For sure, complicated sample, parapneumonic, and empyema, all of them are exudate effusions. How we can say this effusion is transudate or exudate? It's with the Leitz criteria. Leitz criteria, we take the sample after the thoracocentesis to know if it's transudate or exudate. If meets any of these criteria, it's enough to say it's exudate. If pleural fluid LDH on the serum LDH is more than 0.6, or pleural fluid protein on total serum protein more than 0.5, or pleural fluid LDH is more than 2/3 the upper limit of normal serum LDH. If the three are negative, it's purely transudate. If one is positive, it's an exudate. We will begin now talking about the empyema and parapneumonic effusion, which is our main topic. The incidence of parapneumonic effusion depend in part on the infecting organism. For example, a parapneumonic effusion, as the name of a parapneumonic effusion, it always comes with a pneumonia. Patient who is having or experiencing now a pneumonia, and after having the pneumonia and at the same sides of the lung, he will develop the effusion. For example, a parapneumonic effusion occurs in 50% of Streptococcus pneumoniae infection of the lung, but the organism can be demonstrated in pleural fluid in fewer than 5% of patients. Pleural effusion also develop in 40 to 50% of gram-negative aerobic pneumonias, and the majority of these are culture positive. It's not that common to have a gram-negative infections with the pneumonia from the community, like the E. coli, like the Klebsiella. It's not that common. This effusion, maybe it's acquired in the hospital, and this effusion have a higher probability of acquiring parapneumonic effusion. Pseudomonas species, E. coli, account for more than 2/3 of all infection of the pleural space caused by aerobic gram-negative organisms. They are the most two common organisms in gram-negative, not in all. Pleural effusion occur in 30 to 50% of patients with pneumonia due to atypicals, like the Legionella species. This is some pictures for patients having an effusion. We will talk about the ultrasound in details also in the coming. Pleural infection is a spectrum of condition. It's have a lot of names. We can say the first one, the most common known, which is simple parapneumonic effusion, which is a pneumonia associated with pleural effusion on the same sites. Whereas complicated parapneumonic effusion and empyema refer to infection of the pleural space. Although these suggest distinct entities in many patients, there will be a continuous progression through these phases. So it's a term, saying pleural infection is a term used to have to go or to be towards the chronic parapneumonic effusion and empyema, referring to the likely presence of bacteria. So that's we are saying it's a pleural infection. Simple parapneumonic effusion is characterized by pleural effusion associated with parenchymal consolidation. So we are having consolidation and we are having parapneumonic effusion, but once doing thoracocentesis, the pleural fluid culture will not be positive. It will be negative. The organism will not be identified in the effusion. Typically, pleural fluid will be like the transited one. It will be free flowing on ultrasound, no septations, no loculation, and it will be anechoic, so it's completely black. It's not echogenic, not accompanied by pleural enhancement on CT, so it's not very dark in color on the CT. And on aspiration, the pH will not be as very low pH because the organism is not present. There is no active infection. The pH will be more than 7.2. This is the simple parapneumonic effusion. And as I told you, the negative microbiological culture, it will never be, after the thoracocentesis, isolated from the pleural fluid. It is often the result of undertreated pneumonia, increase the pleural membrane permeability secondary to inflammation, and fluid leak into the pleural space. This stage is known as the exudative one, and this is the simple parapneumonic effusion. Complicated parapneumonic effusion is associated with ongoing inflammation of the pleura. The terms complicated refer to the needs for drainage to achieve resolution. It's complicated, so we don't treat it usually only with antibiotics. It needs to be drained. It is associated usually with bacterial invasion and phagocytosis within the pleural space. And after that, with time, the development of fibrin stranding within the pleural fluid. And this fibrin stranding, this is the septations or the loculation that will be present on the ultrasound machine. As we begin, the parapneumonic effusions pass through three phases. The first one, the exudative stage, where we are saying it's a simple parapneumonic effusion. The fibropurulent, which is the second stage, and the last stage, which is the organizing. The exudative stage, characterized by accumulation of sterile pleural fluid. We are saying it as sterile because there is no bacteria. It's a reaction to the pneumonia present on the same sites. As a result of that, inflammations lead to an increase in capillary permeability. The increase is caused by the release of various cytokines like interleukin-6 and interleukin-8 and tumor necrosis factor and vascular endothelial growth factor. As we previously discussed, in this patient, pleural fluid has a glucose level which is normal, pH more than 7.2, and it can be resolved by antibiotics. In the fibropurulent stage, bacterial invasions happen, lead to endothelial injury, and this is the cause of pleural fluid accumulation, which gives rise to decrease in fibrinolytic response, deposition of fibrin, which cause the loculations or septation on both the pleural surface, and as previously discussed, the formations of loculations. At this stage, pleural fluid has a large number of neutrophils, polymorphonuclear cells, and in the cytological analysis of the effusion, it will be neutrophilic, so it will be exudate and more neutrophilic than lymphocytic. Bacteria and cell debris. The increase in local metabolic activity can justify why the pH in this stage is less than 7.2, why the glucose is low, and why the LDH level are very high. This image summarizes all what we have previously said. Presence of this stage is for sure the fibropurulent one, with the presence of fibrin membrane, the presence of bacteria, the presence of phagocytes, the the inflammations of the pleura, and the accumulation of fluid. And this fibrin membrane, it represents the loculations or septations. That's why maybe lots of loculation are not communicating with each other, and it's not simply drained. The last stage, which is the organizing stage, various growth factors appear, including basic fibroblast growth factor, platelet-derived growth factor, transforming growth factor, establishing the final phase, characterized by the depositions of this fibrin and eventually fibrous collagen tissue. Most patients reaching this stage maybe will not improve only with the drainage and the antibiotics, and maybe needs more further interventions that we will be discussing. These three stages are usually sequential and progressive. Although this patient must be treated promptly, in 50% disease does not progress to the fibroproliferative phase, which is the last one, even 3 weeks after the start of the process. So that chest drainage tube, fibrinolytic agents, which we will use only for the third stage, and maybe surgical intervention, like VATS, video-assisted thoracoscopy, can sometimes be effective in later stages. The microbiology. Parapneumonic effusion occurs during the clinical course of more than 57% of bacterial pneumonia, and 5 to 10% of these patients develop empyema. The presence of parapneumonic pleural effusion should be considered in all patients with bacterial pneumonia. It can affect patients at any age, but it's more common in aging adults and children, and especially in patients with chronic conditions such as diabetes, alcoholism, aspiration risk factors. When pleural effusion is associated with nosocomial pneumonia, as the gram-negative one, which is acquired in the hospital, the prognosis is poor. Patients recover more slowly. Length of hospital stay is longer, and the microbiology is different. The microorganism most often isolated is community-acquired pneumonia are gram-positive aerobic and anaerobic bacteria. This usually happened as a parapneumonic effusion sample or complicated with CAP, while this associated with nosocomial for sure will be something like the gram-negative and the staphylococci. Empyema caused by gram-negative bacteria are more common in patients with comorbidity. It's not that common in normally immunocompetent persons, especially diabetics or alcoholism. Diagnosis. The presence of microorganism or purulent content in the pleural fluid confirms the diagnosis of parapneumonic effusion. But if we are having a pus, it's empyema. We never say it's empyema without seeing a very turbid fluid or a frank pus. In the absence of these signs, the diagnosis of parapneumonic effusion is presumptive. Parapneumonic pleural fluid, as previously we said, it's polymorphonuclear exudate, and the effusion evolve in parallel with the resolution of pneumonia in response to antibiotic treatment. Pleural fluid must be tested for infection in all patients. That's why, as a part of any pleural tapping done, thoracocentesis, it's have to be sent to the microbiological lab. However, cultures are negative in most patients, and in such cases, pH and biochemical marker are a valuable diagnostic and prognostic aid. And cultures are negative. It can be negative even if in the stage of complicated parapneumonic effusion, and even in empyema because of starting antibiotic earlier. It can be false negative, but we will see if it's an infection with the aspect of the fluid and the biochemical analysis, very low pH, low glucose, clinical manifestations, and radiological by ultrasonography of empyema, and also guided by the response to antibiotic therapy. The pH value is the parameter that best identify infected parapneumonic effusion. However, a pH under 7.2 does not have 100% sensitivity. Low pH can happen with malignancy also. So that's why it's not, without clinical symptoms, it's not 100% sensitive that we say if low pH, it means an infection. In such case, a glucose level below 40 and an LDH level more than 1,000 can be useful alternative in identifying infected parapneumonic effusion. In loculated pleural effusions, the pH can vary between one pocket and another because it takes time to reach the complicated stage, and they haven't all began the complication on the same time. Clinical presentation of a patient having Parapneumonic effusion, the classical description of non-resolving pneumonic symptoms such as cough, sputum production, fever, in conjunction with chest pain. Chest pain is very common complaints, especially pleuritic chest pain with patient having pleural effusion. And the examination finding of a pleural effusion are among the most straightforward pointers to pleural infection. The mainstay of imaging in pleural infection remains the plain chest radiography because, as we previously said, very little amount of fluid have to be identified in plain chest radiography. Ultrasound and contrast enhanced CT. Ultrasound finding in transient or simple parapneumonic effusion, as we previously discussed, it's anechoic fluid with little or no septation and freely floating lung. Echogenic fluid appearance point to an inflammatory exudate, maybe hemothorax, maybe frank pus. So it's not something transudate with echogenic fluid. Septation indicates the presence of fibrin and the complications that happen within the effusion, and loculation represent discrete collections, so they are not communications, they are not communicating together, and the drainage will be more hard. This picture of the ultrasound, it points towards septations, and the fluid appears echogenic. Also appear echogenic here in the CT. It's not appear to be free flowing on the chest X-ray because it's somehow loculated here on the right side. The most common organism isolated by microbiological was Staph aureus. This is worldwide, followed by Streptococcus viridans with Klebsiella and Pseudomonas following this. Of concern of clinicians should be that within Staph aureus, only 67% of community acquired and 42% of hospital acquired were methicillin sensitive. For guiding antibiotic for sure, when considering community acquired versus hospital acquired infection, the relative risk factors of inpatient must be considered with high rate of aspiration, hospital acquired pneumonia. Accordingly, the rate of gram-negative gut bacteria are higher in the proportion of methicillin-resistant Staph aureus. This concludes that the gram-positive is more common to be isolated from the pleural fluid, even if the community or hospital acquired, followed by the gram-negative. The gram-negative is very low in the community, but it's very high in the hospital acquired, and anaerobic infection is high also in the community acquired as the gram-positive one. And as we have previously said, that the most common organism is Streptococcus viridans in the community and Staph aureus in the hospital. The treatment. Antibiotic therapy forms the basis of treatment of all parapneumonic effusion, but there is still debate about the indication and timing of other pleural treatments other than the antibiotic. For sure, any pneumonia, parapneumonic effusion should be treated with antibiotic. The antibiotic regimen should be chosen taking into account whether the pneumonia is community or nosocomial, the characteristic of the patient, the microbiology peculiarities of the local geographic area, and the activity of the chosen antibiotic in pleural fluid. Some antibiotics are not good for penetrating the pleura, taking into consideration, for example, that the pH of pleural fluid is acid and the penetration capacity of the antibiotic may be decreased in the presence of thickened pleura, particularly in empyema. From the groups of antibiotics that are not much used in infected pleural fluid are the cephalosporin because of low penetration to the pleura. Yes, the penetration of cephalosporin into the pleural space is low, but concentration are stable and persistent. The penetration of quinolones is better than that of the penicillin, and the pleural penetration of aminoglycoside is reduced in empyema. The treatment regimen for cases of complicated parapneumonic effusion or empyema must include coverage of anaerobic bacteria. Duration of treatment depend. We are talking about empirical for sure. Duration of treatment depend on the bacteriology, the effectiveness of drainage, and the resolution of symptoms. Resolution usually takes over 2 weeks, and monitoring with the inflammatory markers such as CRP can be used, particularly in the case of indolent disease. In culture-positive pleural infection, whether culture from the blood or from the pleura, targeted antibiotics are advised. In culture pending or negative case, empirical broad-spectrum antimicrobial cover is indicated according to the local prevalence and resistance profile. In contrast to the treatment of pneumonia, the cover for the atypical infection as the Legionella and Mycoplasma is not routinely required, with atypical organism rarely causing pleural infection. Anaerobic cover can be achieved. The most two commonly used, the metronidazole and the clindamycin. Gram-positive and gram-negative organisms should be treated, and penicillin-based antibiotic with a beta-lactamase inhibitor or a third-generation cephalosporin are recommended. Treatment for MRSA has been typically reserved for hospital-acquired infection. However, with the increase in the incidence of MRSA within community-associated cases, the addition of vancomycin should be considered in those not improving by the standard antimicrobial therapy. Second lines of management after the antibiotics, we are considering the pleural drainage. Optimum size of the catheter is still a cause of debate. Maybe they are saying in a lot of studies that large bore tube for empyema is better than the smaller one, but other studies say it's don't differ. Simple parapneumonic effusion often resolve with antibiotic alone and don't routinely require drainage. So we are not usually in simple parapneumonic effusion, as we are saying no loculation, no septation, pH more than 7.2, not thinking for doing the drainage or inserting a drain. Worsening clinical parameters of sepsis, the effusion is increasing, or if there is complications, it's developed to complicated parapneumonic effusion. It should prompt resampling of the effusion to assess for progression to complicated parapneumonic effusion or empyema. Early drain or chest tube insertion is well established as one of the cornerstones in effectively treating the complicated one and the empyema. And the delayed for insertion of the drain, more loculations, more fibrosis for the pleura, and more need for surgery. Once the patient's condition has improved, a decision has to be made about when to remove the chest tube. What is the criteria for removing of chest tube in parapneumonic effusion and empyema? System signs of infection are controlled. It's usually after 7 to 10 days of therapy. And the drainage will be less than 50 ml of fluid is being drained per day. And also, these 50 ml not have to be a pure pus. The color and the consistency has to be improved. The lung has expanded as fully as possible. And if you are suspecting that the patient was having a bronchopleural fistula with the insertion of the drain, it has sealed. Should the lung not completely re-expand and the volume of the unfilled pleural space exceed 100 ml, re-expansion of the lung should be attempted before removing the drain. Close radiographic or sonographic follow-up is indicated to see that the fluid is decreasing and it's draining well, and to see that the drain is present and draining all the roculus present. Successful percutaneous tube drainage of an empyema or complicated parapneumonic effusion should see clinical and radiologic improvement in 48 hours. If the patients fail to improve, the drainage is either inadequate or antibiotic selection is incorrect. Patient with inadequate drainage choices are: maybe there is another loculus. The first drain is not draining it well, so maybe I will insert another drain in the other loculus. Second one, maybe using something like a fibrinolytic agent, try to open this loculation and septation all together with a material to be injected in the first drain to the pleura. Maybe doing a thoracoscopy, seeing the pleura, try to cut these adhesions and open all the effusion together, or surgery with thoracotomy with digital lysis of adhesion, operative placement of chest tube after the surgery. Maybe if the pleura is sick and it's not improving, doing decortication. Third line of management after the drainage which is the intrapleural fibrinolytic treatment provided significant benefit, reducing the length of hospital stay and the number of cases requiring surgery, as well as the duration of fever and or pleural drainage. Intrapleural fibrinolytic can dissolve fibrin membrane and potentially facilitates the drainage of the pleural space, although long-term outcome with this therapy have been mixed. The most commonly used, streptokinase, urokinase, and more recently tissue plasminogen activator have been used in this setting. Diluted in 50 to 100 ml of normal saline solution, this fibrinolytic can be injected through the chest drain into the pleural space. After injecting, it is clamped for. It's different in many guidelines, but in Fishman, it's present for 4 hours and return to low-level suction when tube is unclamped. This form of therapy can be repeated daily up to 14 days, depending on the rapidity of improvement. We are judging the successful response of the fibrinolytic by increase in the amount of drainage. It was very low draining in the first, and then the drainage improved. Improvement in the X-rays or the ultrasound, and decrease in the systemic signs of infections. Adequate pleural drainage is particularly important in an empyema that is accompanied by a bronchopleural fistula. Undrained pleural fluid can spill through the fistula into the lung and cause pneumonitis, diffuse pneumonitis. A bronchopleural fistula is suspected when the chest radiograph shows pleural air fluid level and when a patient raises more sputum than anticipated, especially when the production of sputum is position dependent. So if the empyema or the infected pleural fluid have an air level within it, so we can think that it may result in fistula, and also if the production of sputum is positioning as a chief complaint for the patient. Fourth lines of management, which is the surgical procedure. The option for surgical treatment are thoracotomy with decortication, mini thoracotomy, video-assisted thoracoscopy, rib resection with open drainage. The most commonly used is video-assisted thoracoscopy. Is the option most widely used in the last decade, seeing the pleura, seeing the loculations, the septations, the adhesions, and try to accordingly see if it's enough to doing adhesiolysis or doing decortications together. This procedure is in general associated with more favorable outcome, reducing the length of hospital stay, the number of post-operative complications, and the duration of surgery, although randomized trials are needed in this area. In organizing empyema, however, thoracotomy is required between 10 and 29% of cases due to failure of video-assisted thoracoscopy. The prognosis for all these patients is difficult to clearly define prognostic factors because such a wide range of treatment approaches are used. Purulent pleural fluid, delay in starting the drainage, comorbidity as diabetes, and loculation are all associated with a poor prognosis. This diagram maybe it's concluding the most important point that medical history, physical examination, presumptive diagnosis of parapneumonic effusion, laboratory test and chest radiography, start antibiotic. If pleural effusion is more than 1 centimeter by ultrasound, do thoracocentesis, analyze the fluid. If it's pus, drain. If no, wait for the analysis, pH, gram stain, and culture. Do ultrasound and accordingly see if it's enough to do antibiotic therapy, if it's simple parapneumonic, or we are in need for pleural drainage and other interventions, fibrinolytics, VATS, decortication. This also is concluding everything from the non-significant one with the antibiotic treatments to the simple parapneumonic, complicated empyema. All of it from the simple ones not need except antibiotic. When it's borderline complicated, simplex or complex complicated, it will need drainage and fibrinolytics. In complex complicated, it may need video-assisted thoracoscopy. In a great majority of patients with empyema, with a lot of loculations and the drain is not working well, we have to go antibiotics, drainage, fibrinolytics, and considering video-assisted thoracoscopy. Thank you.
Thank you. Marwan, I think Dr. Sabbagh had a question before.
Okay. Hi.
I just raised my hand by accident. I don't have a
Okay.
question. Thank you very much.
Thank you. Anyone have a question?
Yeah, I have one. Sorry, I can't raise my hand because I'm on the phone.
No problem.
Just a question. I don't know if it has been mentioned in the presentation or not, but what are the chances of recollection of the empyema after having decortication already? Because I've seen this in one of the patients in our ICU.
It can
I didn't,
it
I
can
didn't get
eventually happen, but
where will be the collection if the patient has a decortication, or is this something that can be expected after decortication?
if decortication done, the most common complications that happen is continuous air leak. It's happened with the decortication. But if we have removed the pleura, costal pleura, the second layer of the pleura, which is the visceral pleura, it's very rare for the empyema to recur because the infection and the bacteria was present on this side, on the visceral pleura. So it's not that common that empyema recur after that. It's the thoracotomies that have been done and the decortication is the last step in patient with empyema.
So it's very unlikely if you find
Very
infection after the decortication.
Yes, and we never think of decortication
Right?
after failure of all the previous one.
Okay. Because that's what I've told them. If the patient already came from a decortication operation and there is I don't think we should treat it as an empyema. It might be like a lung abscess or a neoplasm or whatever, but they were convinced like, no, it's just recollection of the empyema.
And they have inserted the needle and it was pus?
No, they've just been referring to cardiothoracic to treat. But the main
it's very unlikely
and treating
to recur because you have completely removed the bacteria and the fibrosis which is present around the lungs. Maybe the patient has a lot of comorbidity, immunity problem, and this is why it's recur.
All right. Thanks, Dr. Marwan.
Thank you. Any other questions?